we're addressing some of the shortages that are out there, how we are making sure our staff is taken care of, and of course, the big thing about this is taking care of the providers so the providers can take care of us, right? So we're going to talk about that as well as how are we addressing these concerns. And I have great guests from really literally all over the country that's going to kind of chime in with their thoughts. I have three chief medical officers from some great organizations that are going to be talking to us. And I'm going to actually go through them from the top left to the right to the bottom of the screen, and I'll welcome them individually. So first of all, I want to welcome Dr. Eric Summers. Welcome to the show.
Hey, thanks. Happy to be here.
Yes, sir. So Chief Medical Officer over at Wake Forest. And in just a minute, I'm going to ask you to give us a little bit of a background of kind of a little bit more about your organization. I know you've got some recent changes. We can cover that so you can get an idea of the scope of your organization as well. So appreciate you being here. And also on the right, my right, I have Dr. Danielle Madrill. She's the Vice President and Chief Medical Officer at Centra Medical Group. Welcome to the show.
Oh, thank you very much. I'm excited to see where our conversation takes us today.
Absolutely. And then I don't know if you can see it, Dr. Madrill. You're a little bit off to the left. So if you can move to your left a little bit. I mean, a little off to the right. Excuse me.
All
Move
right.
to your left.
All
Yeah.
right. There you go.
Up. It's just the opposite. The other way. Sorry. Keep going. There we go. Perfect. Perfect.
All right.
Okay, and I'm also very excited about Dr. Michael Torres. He is the Vice President and Chief Medical Officer at Advent Health. Welcome to the show today.
Well, thank you very much. I look forward to the conversation with my colleagues and the audience.
Absolutely. We are too as well. And those who are just now chiming in, let us know where you're coming in from. If you're watching us, what city, what state, what country. And now notice I'll drop my phone. I want to make sure I catch the comments as we talk because we want to hear your questions and your feedback as we go along. We want to know what it's like in your part of the country. So just to kind of give an idea of the scope of the organization, I'm going to go back through our guests and let us know where you are physically, what your catchment area is, if you will. And we'll start off with you, Dr. Summers, and then Dr. Madrill, and Dr. Torres.
All right, I'll start. Thank you. So I'm here at Atrium Health Wake Forest Baptist in Winston-Salem, North Carolina. We're a 850-bed hospital, academic tertiary care center. Regionally we cover western and central North Carolina. Big area that we cover. We have 5 hospitals in our regional health system, but recently we came into a partnership with Atrium Health, which is a large organization out of Charlotte and covering Georgia, Alabama, big region. So now we're huge. We're 40-50 hospitals, and we're excited about that. That's a big transition for us, but that's where we're at.
Awesome. Yeah, so that's great information. I'm very familiar with Atrium as well. There are actually several returning guests on the show from there. Dr. Madrill, how about your organization?
Great. Well, I'm at Centra Medical Group and Centra Health System. We're in Lynchburg, Virginia, pretty much the center of Virginia. Our caption area is about the size of the state of New Jersey. And we cover a little bit about half an hour from Roanoke to our west, about an hour to our east, Richmond, and then all the way down to Danville. So we partner. We have about 500 employed physicians, and I'm the chief medical officer for that group, but really partnering with the health system on a system level, 4 hospitals, over 62 outpatients, and 4 freestanding urgent cares and emergency departments. So pretty busy group of physicians and caregivers in the area.
Absolutely. Appreciate that. And how about you, Dr. Torres?
I am the Vice President and Chief Medical Officer of a 425-bed facility that is a rurally designated hospital. We're in Ocala, Florida. Horse capital of the world, they like to say, but we are opening a world-class swimming and aquatic center here that's going to be training Olympic athletes. And believe it or not, Ocala, Florida, no snow, now has 4 Olympic medalists in speed skating that are from Ocala. So this is becoming a destination for not only horsemanship, but also all kinds of sporting events. We have a pediatric emergency department, pediatric inpatient. We're full service, neurosurgery, cardiac surgery, soup to nuts. 2 freestanding ERs out in the community, as well as rural health centers that we're with. And so we are a full service facility in the north central Florida area.
Very nice. Okay, so and folks who are watching, let us know what types of organizations you represent or that you're coming from. We want to see what kind of folks are on the call. Let's also be sure and use this as an opportunity to network with each other, share ideas. That's kind of what we're here for. So one of the things that we talked about just before we got live was we were talking about some of the things that are top of mind for each of you. And I'd like to go through, give each of you an opportunity to chime in on that. And so it could be anything from staffing shortages, how you're addressing those. It could be maybe we're going to celebrate some wins, things that are going on. There are new things that are coming along. How we're addressing issues where it comes to the nurses as well as with the physicians, perhaps other staff that also support the providers. Any of those things, would love to hear about that. So what's top of mind for each of you? And let's start off with you, Dr. Torres, and then we'll go with Dr. Madrill and then Dr. Summers.
Staffing, lack of, and the stressors that places on the people who put on the uniform, the stethoscope, the face cover, the hair cover, and come in and do work every day. Whether that's stress that is expressing itself in depression or anxiety, or whether they're having PTSD events because of the increasing violence we're seeing against healthcare workers across the country, not just here in my hospital, but also the moral injury that they're facing when they can't live up to the things that they wanted to do, whether it's a physician's oath or a nurse's oath. I've got more patients than I can handle, and I'm stretched too thin, and I can't do all the things I want to do. People are feeling like they are not living up to what they should be doing for patients. And so it's not only the burnout amongst the medical staff. We have a very active program for that, but also the burnout amongst the nursing staff, the technicians, and even the registration clerks. When people are lined up in front of you because you can't process every person that's showing up in front of your desk or your kiosk. For me, that's the biggest problem that at least our executive team is dealing with here. And I would say across our, Advent Health is a 51 hospital enterprise across 9 states, and all of our CMOs talk to each other, and we're all saying the same thing. So it's across our whole enterprise.
Yeah, makes sense. Okay, so what about for you, Dr. Madrill?
It's very similar to Dr. Torres. The thing that's very painful to see is that the moral injury that our caregivers are suffering because they really feel that they're not being the best that they can be. And so focusing on how do we, have the patients have a good experience, and also balance that with the care that we have to give our physicians and our care teams. The one thing that's kind of interesting is, how do you keep them engaged, and how do you keep people focused on the mission, right? So trying to get everyone to understand, we may not be doing it perfectly, but given, the situation we're in, we're doing the best that we can, and really helping people do a little bit of mindfulness and reviewing, how to have grace for themselves and their team, and having hopefully the community sort of also sense that we need a little bit of appreciation. And it's kind of interesting. Dr. Torres mentioned the increase in violence, and that really has been shocking to me, that culturally, even in our rural settings, that does exist, right? And so it's something that you think it would happen in a big city, but it happens rather frequently. And so balancing being able to care for the patient but also care for your team is critical.
Wow, those these are all issues I definitely want us to see what we can do to tap into each of them. So how about for you, Dr. Summers? What's top of mind for you at the moment?
Well, it is interesting. It's almost like a broken record. It's very similar things, although that we have one caveat. But first, I'll mention, staffing. Supporting our staff, keeping our staff, hiring new staff. We're really having to emphasize that as in certain key areas, nursing, care coordination, nursing assistants. There's many areas where we take pride in our culture, and we feel like we have supported our staff very well, but we need to do better. We need to do with the high capacity issues that we've had over the last year and a half, the stress. We're realizing that we've got to come up with new models. so that we have the staff to take care of our patients. Because alternatively, the patients aren't in the right place. When you have high capacity and you can't get patients where they need to be, they back up in your ED, or they're in a hospital, a small hospital that can't even get to the tertiary care center, and that is extremely tough when you know you need to take care of someone that and you can't get them where they need to be. So they're in combination. The thing that's maybe a little bit different with us is we're doing all that in the setting of a new relationship with Atrium and this integration, so that's just another piece of the puzzle we're working through. But yeah, I think it's very similar to what my colleagues are saying. It's staffing and high capacity issues.
Yeah, and we've got some folks who are also commenting and coming in here. We have Yitz Rubin, welcome from Chicago, Illinois. We have German Kaiser Santiago of Chile. He's there. Wow. We also, and Yitz he says starting with Altius Health in March, which provides cardiologists and pulmonologists for nursing homes in Illinois, Kansas, Wisconsin, and Missouri. Okay, well, thanks for sharing that. And the rest of you who are, I see quite a few others are on here. Feel free and let us know what type of practice setting that you're in, and let us know some of the challenges you're facing. Perhaps we can brainstorm with some of those things as we're speaking here on this call. So I want to kind of go back to the shortages. When you think about some of the shortages, just from your purview, your perspective, are some things starting to emerge as ways to deal with some of those shortages? Because there's certain amounts that we just have very little control over, more than others. So, Dr. Madrill, has anything come to mind or that you've seen or that you've experienced that's kind of helped to move the needle even a little bit when it comes to dealing with these staff shortages?
I think the best thing that we've done is become very creative of having all our practitioners practice at the top of their license, and then figuring out ways to kind of decrease the pebbles in people's shoes, to take away some of the busy work that we had traditionally been having everyone do from the entry of the office all the way through the visit. So part of that has been, I think, well received. You can help support the staff a little bit that way. Um, I think the advent of travelers, right, and the compensation for traveling providers. I mean, now, even to the point of physicians, it's going to be difficult. How do you keep that person there? So you really, as an organization, have to figure out. Sometimes it is the money. So part of that is the compensation of all of your providers, but then also how do you make it a great environment, and how do you do that during these very stressful times? And so that's the challenge we find is the traveling, the high value for traveling right now is really hurting local communities, right? Because we're losing a lot of our local staff to other areas.
Yes, I've heard that quite a bit of nursing as well. And I can tell, Dr. Torres, you got something you wanted to add to that. Did you want to add to that part?
I am aware of nurses that live within 20 miles of my hospital who were employed here, who quit to go travel, and then they gave a family member's address in another part of the country. They still live within 20 miles of my hospital, and now they're back making twice their salary as a traveler and extending their contracts because they're just, taking advantage of the opportunities.
Mhm.
My hospital is currently spending in excess of $5 million a month on travelers.
Wow. Wow. I have to sit back and kind of let that that sink in there. 5 million a month in travelers. Oh my gosh. Okay. Yeah, that's
That's not
significant.
just nursing. That includes traveler respiratory therapy. That includes traveling physicians.
Everything.
Okay, we had some older physicians that decided that during this world crisis, we're done. We're going to retire, and so I'm paying for a locums GI doc every day. You know, so you know,
Yeah. Yeah. Okay. So and there's going to be a complex answer to how to fix that one. So I don't know what that answer is, but maybe we can come back to that in a few minutes. Any fixes you found on your end, Dr. Summers? And by the way, I also want to come back to your point, Dr. Majul, about work at the top of your license. I want to come back to that too. But Dr. Summers, what were your thoughts?
Yeah, I mean, we certainly have changed some models. Top of the license is a great statement. That's what we've been trying to do. but really we haven't fixed this issue. I don't know how much money we're spending, but it's probably in the same general area as what Dr. Torres mentioned. It's a new model. It's a new world almost, and so we've got to figure out how to adapt to this. The thing that makes it really difficult is, to Dr. Torres, he says that we spend 5 million. Well, the way I look at that is that's 5 million that we're taking away from patient care. I mean, that's money that we might use for something else to help our patients. And so how do we bridge this? And there's we've talked about, and we have the same nurses that live 20 miles away, although they don't give a different address. They just tell us, we live 20 miles away and we need them. We need their expertise. And the other piece of this that we haven't really talked about is the veteran nurse, the nurse who has 20 years of experience. We're losing those nurses through retirement, through many different avenues. So our frontline staff has become very young, and young is great. You have energy, you want to do great things, but experience is huge. Who's going to teach that generation? And so these are things that we're talking about almost daily, and I wish I could give you an answer how we've solved it yet, but we haven't solved it.
Okay, well, so I do have some questions. Thanks you for folks who are already put in your questions. I'm going to get to these in just a moment. I just want to present an idea, and then I'm going to read a couple of questions, and then I want to hear your answers to either to the questions or the idea. I'm curious, because of the lack of nurses, what are some inventive ways we can think about to perhaps use the LVNs and the techs and the aides, or let's just say the techs and the aides, to do more to assist the RNs so that they can work top of license, and then the RNs perhaps, what are some things that they could perhaps not do possibly that could make them perhaps expand the patient load? And then could we get to a point possibly, do you think, in the future where you have nurse practitioners who are sometimes working as RNs, right, because there's not enough positions for them? Perhaps they're in the mode of doing some things that the RNs may have to do, and maybe there's, for lack of a better term, supervising a set of RNs to perhaps help everyone work top of license, similar to what I've seen years ago kind of happen with the physician model, where you have the physicians who are supervising several PAs or NPs. So I just kind of want to just at least throw the idea out there, and then you guys can kind of talk about some of the pluses and minuses. Then I'm gonna read the question, because I want to give you time to marinate on that. I'm going to read these questions, and whoever wants to answer one of these questions, feel free and pipe in on this. So the first one we have is Dr. Chad Key. He says the pandemic has revealed a new set of psychosocial issues for patients that influence transitions in care, discharges, and length of stay. Do you think the future of care will involve home care? How can executives support the hospitalists and physicians to advance these goals? Who would like that one? Dr. Summers, go ahead.
You start. Dr.
Okay.
Madrigal, I'll defer to you.
Go ahead.
Oh yeah,
Dr.
I was
Madrigal.
just, it's interesting. If I would say the emergency department, right, is the ground where every community suffers the most, because people are used to going there to grab healthcare. And so, with the advent of all the CMS rules and the readmission rates and what we're tied to as organizations, we've really had to become creative. So it's the hospital at home is a project we're doing, the remote monitoring, right, for all our congestive heart failure patients. So you have to get very creative as an organization. Again, the staffing is a problem because you're kind of supporting that, but you're taking staff from the hospital or you're taking staff from the clinic. And so you kind of have to balance how big you want to make that project and that availability to your patient population. But it is one of the ways that we're decreasing the capacity load within the hospital. So I think those are things that we're managing as best we can.
That's great. I noticed that y'all couldn't see the live screen. You could only see me, so I'm just giving an opportunity. Now you can see the live screen. Okay, Dr. Summers, go ahead. What's your thought?
Yeah, I was going to say that the pandemic's certainly given us a lot of difficulties, but it has caused us to think outside the box. And we have a hospitalist at home program that has been fairly successful. 20 to 30 patients at a time are at home where they otherwise might be in the hospital. We have a EMTs that go out to the house and help with the video and working with the physician. Absolutely, it does pull some resources away from the hospital. But interestingly, if you don't have the staffing to staff the beds, then you know you can use that resource to go. So we're trying to be creative and really the goal trying to maximize our beds because people need our help in the community and so yeah, that has been telehealth is certainly something that we are rapidly growing with because we need to.
Excellent. Okay, Dr. Torres, would you like me to read the next question, or did you have something you wanted to add to this one?
I was going to add to this one.
Please.
We too are using a community paramedicine program. We actually sponsored that with both the county and the city. We are using telemedicine as well. We are using the LPN model at top of license. They are now on every team from the emergency department to the ICU and everywhere in between. We're using LPNs. We have partnered with schools of nursing and even the patient care technician training, CNA training, where we're taking people who are completely non-certified, hiring them, paying them a salary to go to school while we pay the tuition for the program, and then they get a raise when they get certified and they come in onto the workforce. They do all their clinical time in our workforce while being paid. So we've done a number of innovative things here to try to make sure that we are casting as wide a net as we can to bring people in, and we have maximized the use of telemedicine so that a physician who the neurologist who gets a non-stroke consult can actually just dial in, and we've got the computer in the room, and we're even now doing virtual nursing. So we've got every one of our floors by the end of next month will have virtual nursing capability in every one of the rooms. And again, we're north of 400 beds. So, we are going to be able to do virtual nursing in every location in the hospital so that people who are either afraid of exposure to the illnesses in the hospital or who can't tolerate the patient movement and lifting. I've hurt my back, but I'm still a bright nurse. Virtual nursing can be done from the comfort of their home, while they log in, and it's working well. So that is certainly the type of things we're doing.
Oh, that sounds exciting. I like that. I just want to check in with the audience on that. Yeah, look at that.
Can I make one other quick comment on that?
Please.
Is that we're doing the same thing, top of license, but one thing we're learning is that on paper, what we think top of license and how it will go well, that there are these unintended consequences or concerns that we didn't realize. So it becomes critically important that when you make these decisions, that you get the feedback from your nurses and your NAs. For instance, some of our virtual nursing consideration or some of the projects, we got feedback, well, the nurses that are on the floor are having to do more for that, for the virtual nurse that isn't there. So you have to be very attuned, because if you're doing something that you think is good and and then a group of your staff is unhappy, they could leave. And so we're making a lot of quick changes in an environment where we need to, but you've got to be cognizant of what your staff is thinking.
That's a great point.
Yeah, and I'd add to that, again, healthcare has changed so much. So we've had a lot of opportunities to test out new things that before we would have been hindered or reluctant to test out as healthcare providers. But we've gotten to the point now where, we have a lot of opportunities to think differently and use innovation. But to Dr. Summers' point is, we can make it easier for one subset of providers and then really add to a burden of another. And so unless you do this in a very collaborative methodology, you're going to end up losing the people that are really the glue of the organization. And so that is one of the things that you have to be very mindful. And of course, we haven't even spoken about behavioral health and the crisis that we have there. We haven't spoken about the electronic health record that is a stressor for everyone. And, the tying our reviews to patient experience. So those three things on top of our current world are stressors that are really, I would say, on my mind constantly.
Oh, well, those are great points. Okay, so I've got some folks chiming in. By the way, that actually, you just brought something from, I got my recruiter hat on here. And so I was just thinking, with the virtual nursing thing, as long as they've got a license in that state, they could be virtually anywhere in the United States, right? I mean, is that am I on pace with? Okay, so that could actually help. Okay, that could actually help recruiting, because now your recruiting staff can pull folks from anywhere in the country to help with some of the virtual nursing. That's fantastic. And also some of the local people who get just burnt out from doing all shifts in person, maybe some of them can do some shifts in virtual too. I don't know, just a thought. Okay, I'm going to read some things here. All right, so Dr. Brian Tobin, he says, my background is in founding 4 new generation AAMC medical schools to meet the needs of medically underserved and disadvantaged communities. And his question is, what is the current status of intra and inter IT operativity in EMR within and between healthcare institutions? That's a big one there.
I said, who wants to take that one?
Yeah.
So, yeah.
Oh.
Y'all probably going through that right now, Dr. Summers, right?
Go first. Eric, you go first.
Yeah, I guess I'll be the one to. That's a complex question, so I'm not sure exactly what direction he's looking to answer, but I can tell you that certainly being able to communicate not just in Atrium Health, but our competitors across the street, regionally, Duke, Chapel Hill, Cone. It's very important for our patients, and so we do have a process through our EMR to communicate with our hospitals. It's not perfect by any stretch, and we continually work with that to improve that. But there are definitely opportunities, but we're looking in that area. Absolutely, because ultimately it's about, all this has to be about the patient. The patient has to come first, and if I'm a patient, my family member, whoever walks in the door, the one thing they want is they want the physician or the medical provider to know exactly what's going on with their care, be it in the moment or in the past. And so, yes, it's an important issue.
Absolutely. Yeah, absolutely. Did either you want to touch on that before I go to my next question?
Well, I think that the one thing that's interesting with the interoperability is, you have to watch who your patients are, right? If you look at our demographics of the elderly over 75, them adopting the electronic apps to really follow their health management isn't going to happen. But then as you tailor your healthcare to the millennials, they're really more into that consumerism. So you have to balance what patient population you're taking care of and how you approach them. But we're very fortunate here. We have one platform for all the hospitals and all the ambulatory settings, and we've built connectivity. So that has been extremely helpful. But when you have outside sources, they don't really communicate. So it becomes, to Dr. Summers' point, very difficult for the patients to feel comfortable because you don't have all the information as they've been referred to us. But, at the end of the day, it's, how do we as a health system figure out how to interact with our consumer?
Yeah, absolutely.
Yeah.
Okay, here's another thought. Dr. Tobin also says, look to the state of Alaska for a novel healthcare system where rural indigenous people are trained and designated in roles of PCPs to triage those who can be treated rurally and those who have to be treated at a major clinical center. Have y'all heard of something like that? I hadn't heard of that before. Going back to your point, Dr. Mergel, you were talking about how when they're older, it's just not going to happen. Do you think that if you had someone who was perhaps maybe even older, right, but they're there at the place training them, hand-holding them on how to do it, and I also want to talk about those who are in underserved areas, maybe poor communities where they may not have fast internet access and a computer and all that stuff to reach it. So I'd love to kind of just explore that, because someone else asked about, let's see, Dietz Ruben asked about telehealth, so that kind of plays into that question.
Yeah, I guess the best example I can use is our hospice caregivers, right? So they go out to rural areas, and depending on what service they have, they may or may not have connectivity to kind of reference back to either the advanced practitioner or to the physician what's going on for that patient. So in rural parts of Virginia, we don't have that access. So it becomes difficult for them to get that care virtually. We do have resources that are used for our caregivers, like a phone and a laptop and different hotspots, and try to do all those things so that the patient gets care. But it's really difficult.
Yeah, makes sense. Do you have any thoughts on that, Dr. Summers?
Well, I was just going to go back to one point about, the Dr. Monroe was saying about the patients, the older, younger. I think we've done a really good job of promoting what we call, it's called My Wake Health, where our patients have the ability to look at their medical record and their labs, and yes, we still have opportunities to educate and try and help those that have more difficulty with that. But it is, in my opinion, changed a little bit how our providers document, and some for the good and
Mm.
some not so much. But um, it's interesting how when I'm on service seeing patients, sometimes they'll tell me, their labs before I know, and it's I think at the end of the day that's good, but I do think that we still have some opportunities to fine tune that process.
Interesting. Wow, find out labs before you do. That's pretty interesting that they're
Yeah,
able to do that. Okay, so and then let's see, Dr. Chad Key says, is this a good time to explore a universal healthcare model, one source payer or public government or state-run health? Any thoughts on that?
I mean, to be honest, I got so much going on with other things that I mean, I universal health, I get it, but I mean, boy, I mean, we got to get the staffing right. It's hard to even take something that large
Oh,
and
right. Okay, got it.
I mean, value-based healthcare. We know we're heading to certain things, but it's hard to be proactive at the
Yeah.
moment. What
Okay.
overall?
Yeah,
Here's
that's a hard one. It's a hard one right now, right? Because we
mhm.
have the push for population health and social determinants of health. And how do we do that value-based care? So it really is agnostic to who the payer is. You just have to start doing it. And so I think it's in our current situation, it's kind of hard to put your head around that and start thinking about that right now.
Yes, yes, makes sense. Okay. Oh, let's see, Dr. Matoris. I might have lost him here. Let's see. Let's get him back. I'm
No?
bringing him back here. Let's see if. Yeah. Let me see if I can fix that here. I have two Michael Tauruses. So I'm gonna let me see if I can. Okay, I picked the wrong one. Let me try the other one. There we go. I think. Let's see. You're back. Can you move for me? There we go. Yes. Okay.
Yeah.
Okay. Now let me get you live. Okay. Let me get you live now. There we go. Dr. Torres, go for it.
Okay, what was the question? I don't
Oh yeah.
remember.
Oh, you could.
Since I
And we
was
could.
gone, I didn't hear the question.
I have a new question for you. How about that? But
Good.
if the last question was, do you think it's the right timing for it to consider a one payer model, just a one kind of publicly run one payer model? And you can give an answer, or I can go ahead and read my next question. What are your thoughts?
I'll give you an answer. I think that
Okay.
we need to have. I think that we need to have some form of coverage for all souls in the country.
Okay.
I think that those who have resources, like they do in Canada, like they do in many European countries, like they do in Australia, those who have resources can have a second layer. I'm retired military. I've got my health insurance from my employer. I'll be 65 soon. I'll have Medicare and I'll have TRICARE. When I retire, I will still have Medicare and TRICARE. So I have the prime. done that. And I think that we should look at something like that so that everyone has access. They don't have to clog up the emergency department. I used to live and work in upstate New York, and I know plenty of Canadian physicians that would work for the province for the basic coverage for all, and people who had second layer insurance could get an appointment during the day, but they closed their offices at 4 o'clock to the primary layer and reopened until 6 or 7 or 8 o'clock at night for those people who had secondary layer, and they got charged more because they had a secondary layer coverage. But you were guaranteed to get in that day. I'm well aware of many nations with socialized or single payer or whatever you want to call it healthcare. I like to say a primary level and a secondary or enhanced level. Okay.
Okay.
In organizations or in countries where there's only a primary level, there can be long delays. You only need to look back at our lifetime and all the talk about the so-called death panels when there was talk about, nationalizing healthcare, to realize that in this country, that's simply not going to be palatable if you don't give people an opportunity to jump the line and not wait 4 months for an MRI or whatever. Okay.
Right.
When I was in Buffalo, New York, I was at the University of Buffalo, academically involved there. We had numbers of Canadians that would come into the United States simply because they wanted to be able to jump the line and get their CAT scan or their MRI in this country, and their secondary insurance covered them in the United States. So they were told they had to wait for their MR, their CAT scan, whatever, for whatever the period of time is. It might be days, weeks, or months. Okay. They would simply cross the border into the United States, hit the malls, go shopping, and then hit the ER and ask for the CAT scan. Or make an appointment in one of our clinics and be seen for a same day.
Right.
Okay, bringing their prescription from their Canadian doctor, which we would validate it was a licensed physician and it's only an imaging study. We do it. Okay, and bill their secondary layer, because the primary layer wouldn't pay us in the United States, but the secondary layer would actually pay better than Blue Cross or any of the other plans we were dealing with. In this country, we're going to have choice, because there will be people that will not want to be considered waiting in line with everyone else as acceptable to them.
Right.
Now we can pass judgment on how those people, feel about themselves and the level of humility. It's still going to be a reality we have to deal with. And so I think we need to be realistic. I think we need to, recognize that I think it is possible, but only if we have a tiered program where people who have jobs and have employers, the employer's cost will go down if everyone has a basement paid by the government. Okay, the employer's cost for that second layer coverage is going to go down because right now they're providing total layer coverage.
Ah, yes.
So I don't think and I'm a former entrepreneur as well. I don't think as a former business owner that my out-of-pocket costs will go up significantly. I think it may go up a smidge, but the reality is part of it will be in higher taxes and part of it will be in a reduced rate that I pay Aetna, whomever, Blues, whomever. Okay, that's my opinion.
Wow, out of all the discussions I've ever heard about this, I don't think I've ever heard. I mean, I'm just not probably as informed, but I've never heard of this whole second layer idea. That's a very intriguing idea that it sounds like it may have legs, actually. Okay, so there's another question here. He says, this is kind of, I guess we're on the billing issues now. What has been the impact on working with health insurers with regard to prior authorization and billing? Who wants to tackle that one? That's probably y'all's favorite subject, right? Billing?
You know, my mama said if you couldn't say nice things, don't say anything. So I keep quiet. How about
Okay.
that? Does that answer your
Okay.
question?
Yeah. we may need to. We may
I'm going
need.
to take Dr. Torres's lead. Nothing.
Okay. We may need to. I mean, look, Dr. Roof, that's a great question, and maybe offline you can touch base with one of the doctors.
So here's the reality. They continue to put roadblocks in front of us with, you know, the need to do prior auths or even retro. They authorized it and then later on denied it. We're seeing that pattern happening as well. Okay, the documents you submitted for supporting, and it wasn't us; it would be the physician taking care of the patient. The documents you submitted that justified us doing the pre-authorization don't match the documents in the medical record once the patient's in the hospital. So we're going to rescind the approval, and we're going to now deny the whole thing. And so I usually end up having to be one of the few people that goes and has that crucial conversation with the patient about how their out-of-pocket $200 is now a heck of a lot more money because now it is an uncovered thing, and their co-pays and deductibles are all kicking in, and you know, so we're seeing that, and I certainly think that there is some differences of opinion about what is important. I won't use the word gamesmanship. Oops, I just did.
Well, does that encapsulate y'all's response, or did you want to add anything to that, Dr. Summers or Madrill, before I move on?
And it's a constant battle. I can't say that it's better or worse. It's just a chronic, constant battle. And so, not much more to add to that.
Yeah, absolutely. And I want to thank, Priya Anand. She talks about her mission at her company is to improve patient experience and outcomes through evidence-based digital innovation and analytics. They're a digital health startup providing remote monitoring solutions for respiratory diseases. Well, all the best to you. We need all the innovation we can get. Okay, Candace says, I worked in an emergency department as LPN, but it will be hard to get anyone inside the hospital with the hospital. Uh-oh. I don't think she finished the comment. Sorry about that. Okay, so if you want to finish that comment, feel free and come back. Okay, now Dr. Tobin says the two-tier layer healthcare of Canada is wonderful. I trained in Canada, worked with Canada for 25 years. A two-tier system could work well in the U.S., similar to Canada. Thank you, Dr. Torres. So you already have another supporter in the audience. That sounds very interesting. Okay, let's get, remember I had an idea I presented to you guys. So what are your thoughts on the idea about this whole thing of kind of shifting responsibilities to the point where maybe perhaps these nurse practitioners who aren't really working full license, is there a future in that, or what are some other ways we can address? Because there's a lot of RNs who want to go to the next level. They want to become ANPs. They want to become doctor of nursing practice. And then they find themselves, in some cases, not having a job and working as an RN until they find something. I know, Dr. Summers, you want to start us off? I think you had some thoughts on that, and we could kind of get all your opinions.
Well, a few things about, you take the group, like, for instance, nurse practitioners, we'll take that group. I mean, when I think of top of license, I think, in our organization, they want to, in the inpatient setting, they want to manage their patients and, certainly connect with the physician, but have as much autonomy as they can. And we've been working with that. Interestingly, I haven't heard many nurse practitioners talk about going back and doing some nursing shifts the other way. I haven't seen that. The RNs, they're in our organization. I mean, they're stressed. I mean, it's as you can imagine, all organizations, they have opportunities to move on very quickly if we're not doing things the right way. We have not looked at LPNs that much, going up. We've tried to be creative with our ratios and in our ICUs and our floors, but I have to be honest, I don't have any great solution to that. Maybe my colleagues do.
Okay, Dr. Madrill, do you have a thought on it? Or?
Well, I was going to say we had to get pretty creative, and I have to say hats off to the nursing leadership within our organization. They came up with a methodology of taking volunteers. We have retired physicians, retired nurses, the students from different universities nearby that wanted to help. So they're helping hands. And one example would be for psychiatric patients or behavioral health patients that need to have sitters. So they would train people that were, you could be the CEO and you're going to be trained on how to help extend care at certain times that there was a high capacity and a high need. So, the organization got creative of training people to do their, extend themselves to areas that is not their purview normally as a provider. So you would have nurses that may be, on the floor wiping tables because that shift happened to be short of our environmental services. It could have a physician leader that on the admin day may be pushing gurneys and doing different things. So I think, it's you have to get creative to use your community and your and I would say even your hospital team for everybody to come together and work at different areas, even though that may not be your primary job within the organization. The other areas that we find a lot of, I call them extenders, nobody likes that, but with anesthesia in our rural settings is how do you do care team modeling in different settings that actually allows that access to care for our patients.
Okay, very good. What about you, Dr. Torres?
We have leveraged our volunteers extensively, you know, in many of the same ways that Dr. Madrill's talked about. So, we're doing that. Like as I said earlier, we're bringing in the LPNs at top of license. We are unfortunately under Florida law not able to take a volunteer and have them sit for a mental health patient, but we are having them sit for the safety patients. The person who's not under a legal hold. Um, the suicidal, homicidal, or substance abusers. There's different laws in Florida on that. So um, I have to use employed staff for those, but I can use volunteers for the 85-year-old demented patient that is in the hospital for whatever their condition is. That we want to make sure they don't get out of bed, wander, fall down, break a hip. So we are doing it for that. And
I'll make a couple comments on that. One, with the virus over the last year and a half, we've had to be cautious with volunteers. I mean, we have people that want to volunteer, but we don't have a volunteer program like we had before. We're slowly, as things get better, we're slowly adding that. So that's another, barrier. We have a similar issue with the transport. We've set up a program where anyone can help out, and which just probably like Dr. Madrill, I'm very proud of that. People that wouldn't normally transport are saying, "Hey, how can I help?" How I may be an administrator, but we have a need, and what can I do that? And that's what makes me proud to work at this place. But we're doing anything we can to help our patients, best we can.
That's awesome. Okay, so just to kind of to wrap up for the day, any advice, anything that you found just in your toolbox that you'd like to share with another chief medical officer that's watching this? Anything that you would want to offer to just any words of wisdom or encouragement, any encouragement, and we'll just do it one by one. Let's see. So, Dr. Madrill, if you want to start off, and then Dr. Torres, and then Dr. Summers.
So I would say, similar to Dr. Torres, I was trained also in the military, and it's one of those things that I always think of mission first, but people always. And so that's really what we have to consider here is that, we have a mission to provide excellent care, make sure that we're taking care of our communities, but we really have to care for our people. And as the chief medical officer, that's our primary focus is to really help our caregivers be able to function.
Excellent. Thank you for that. Really appreciate that. And then, how about from your perspective, Dr. Torres?
So it's interesting. The advisory board published a pamphlet just recently, or a PDF that I downloaded and read, and talked about four things that we need to begin to understand about our workforce. And one of them was we need to be brutally honest with them. If you read what Wendy Dean and others who are dealing with moral injury are writing about that, you begin to see that the people who are at highest risk of moral injury are those who are younger, who are nurses, who are female, and there's a whole laundry list. But what are we staffing our hospitals with? People who are younger and female and nurses and dealing with sick patients, many of whom may be contagious. And I can go down the list of all the things, and I won't belabor that, but our employees need to be told the truth. Here's the reality. If you're going to be on a med surge floor and you think you're going to do 1 to 4, 1 to 5, you're full of it, because you're going to be at 1 to 6 and possibly even 1 to 7. And we're not going to try to staff you at 1 to 7. But when one of your colleagues called out or is put in quarantine because now they've been exposed or they're positive, and I don't have a last minute substitution, okay, then you're going to have to not only try to tackle the guard, but the center too. Okay, you're going to have to take them on. And I'm going to stretch you to 1 to 7 or 1 to 8 until I get somebody in. That's a reality. Okay, we're all in this together. In the meantime, I'm getting nursing supervisors, or I'm getting nursing leaders, or whatever we're doing. My dyad partner, the CNO, my work wife, as I like to say, okay, she's working 7 days a week, and she's coming in scrubs and seeing patients. Okay, you're not alone. But don't think that you're the only one that's overwhelmed. I mean, we need to get to that level of honesty. And if you've read any of Lencioni's books or Good to Great or any of those other books, being brutally honest with people and telling them the way it is exactly what they want to hear. They'll follow you, and that's again, Dr. Madrill and myself with our military background. Before I went to medical school, I was a Marine platoon commander. People will follow you into hell if they trust you, and they trust you if you tell them the truth. Okay, and be honest with them. And even the advisory board is publishing that now, and I think it's absolutely real.
Appreciate that. And Dr. Summers.
Yeah, the one thing for not just CMOs, but for any hospital leader, I certainly agree with my colleagues, but um, especially in this time, go to the front lines, communicate with your staff. Yes, be honest, tell them honestly, but listen to them. Listen to what they have to say. Be approachable. If you go to the floor and people are scared to talk to you, or that's a problem. You want to be there for them. I mean, show that you care. If you don't do that, you can't really know in the moment what your problems are, in my opinion. When you sit in an office and you talk about it, that's not even close to the same. So, a young leader, hospital leader, CMO, go to the front lines, listen to your people, absolutely be honest, and communicate.
Love that. Love that. Okay.
May I add
Sure.
2 things? Number one, General Powell, Colin Powell, had his rules of leadership, and one of them was the day your people stop bringing your soldiers, he said, but the day your people stop bringing you their problems is the day you stop leading them. It's either because you didn't take them seriously or you didn't show them you cared. Either way, you stopped leading them. So that's the first thing. And the second thing, I completely agree with Dr. Summers, but when you're out there asking the question, what can we do to make your life better? Because we all ask questions like that. Actually be curious.
Yeah.
When they say something to you that you're not sure about, don't brush them off. Tell me more. Unpack that for me. Help me to understand. Okay. I want to see the world through your lenses. People will actually, even if they'd end up not getting what they asked for, the fact that you took the time to be curious and learn their perspective and thank them when you're done, okay, will go a long way towards making sure that the people you're blessed to lead actually feel blessed to have you as their leader.
Fantastic. Love that.
I have to say, that really resonates with me because um, when you think of how leaders are made, right? We all had mentors, we had role models, we had people that supported us. So as the chief medical officer, that's the key, is how do you get that pipeline of leaders, and who could you help be the next person to carry and support someone else? And that's really, I think, our role is to listen carefully and really engage. And I love that curiosity. I always tell people I feel like I'm the question master because I'm always asking more questions than they ever expected. And that learning is vital for us to do our job well.
Yeah, yeah. In fact, the conversation was so good today, I didn't get a chance to ask my little fun question, so I guess we'll have to say that for the next time I have you on the show. We unpacked a lot of great stuff today. You guys were amazing. I just want to check in with my audience and just make sure they liked it as well. And yeah, they certainly did enjoy it. You guys were amazing today. Thank you for your time. We're going to say bye to everyone out there. Bye, everyone. Thanks for your time.
Bye, everybody.
Okay, for Sarah, just for a second before you leave, and she's going to make sure that we're clear. And so how was it for you guys? This is your first time doing a stream like this?
Yeah.
I've done a few of these, but it's good. This was good. You just.
Awesome.
Yeah, I've done one before, so this is not my first, but certainly I'm new to it. So.
Okay, all right. Now it's not your first. Is it your best experience?
It is.
Okay.
Can I tell you a whole story? Can I tell you a 5-second story? I did one of these about a year ago, and the moderator said, "You're only going to be on camera when they ask you a question." And I said, okay. So they didn't ask me a question, and I was moving around, walking around, and people told me later, "You looked insane." What's wrong with you? They didn't tell me I was on camera.
Oh, no.